whole problem of biliary dyskinesia. I have some disclosures. Like everybody else, I don't believe that they've influenced me very much in this talk. The functional biliary disorders that we see and worry about consist of functional gallbladder disorder and Sphincter of Oddi dysfunction, which can affect both biliary and pancreatic organs. It's a serious can of worms, as many of you will know, and it's one which we've been exploring with some difficulty for at least a decade. So Sphincter of Oddi dysfunction is actually, when I was still doing ERCP, was actually about a third of my patients were coming through the door saying they had post-cholecystectomy pain, and they knew I was going to fix them quickly with some small sphincterotomy. But I began to wonder a little bit as to whether all of that was actually worthwhile, and we began to question whether Sphincter of Oddi dysfunction actually exists, and if it does, perhaps we could define it rather better and learn how to diagnose and exclude it rather better, and perhaps even learn how to treat it better. So most of you will know that there's a traditional classification of sphincter dysfunction, 1, 2, and 3. Type 1 is basically people with an organic problem with dilated bile duct and abnormal liver tests, probably got little stones or stenosis or something, and are very easily dealt with by endoscopic sphincterotomy. But types 2 and 3 are the dysfunction areas, and they're distinguished by the fact that type 2s are patients who have some evidence of pathology, a dilated duct or abnormal liver tests at some stage or other. And then there's the dreaded type 3, which are basically patients with severe biliary pain, biliary type pain, but no abnormality on imaging. And the problem with those two groups, the 2s and 3s, is that it's very common for those patients to get an ERCP and a sphincterotomy for pain in the hope that it'll help, and maybe some elevated transaminases or maybe a dilated duct. And there's an issue there because there really isn't a normal limit for a post-cholecystectomy bile duct. There's a long discussion I could go into about that, because the bile duct itself might be dilated at the time of cholecystectomy, and the fact that it's 10 or 11 millimeters 5 years later is irrelevant. Now most classifications accept something up to about 10 millimeters, but this is a very fluffy area. But the main problem is that the results are poor. Even in the cohort expert enthusiastic reports, nobody's claiming more than about 65% success. There's a very substantial pancreatitis rate at up to 40% in one series. Patients get perforated, and when they're not happy with the result, they end up on a slippery slope of getting more and more ERCPs and sphincterotomies and stents, and then some of them go for surgery. And it's a common reason for ERCP lawsuits to have a casual ERCP sphincterotomy for abdominal pain and end up with devastating pancreatitis. Patients often complain about that. So we set up an episode study, the evaluating predictors of interventions in Sphincter of Oddi dysfunction, some years ago with NIH funding, and we eventually entered 214 subjects into this study with, as you can see, impressive post-cholecystectomy pain, a bile duct of less than 10 millimeters, and little or no elevation of liver function tests. We did allow some fluctuation of liver tests because that's extremely common in the general population. They all underwent ERCP with manometry of the biliary and pancreatic sphincters, and they all got a prophylactic pancreatic stent to reduce the risk of post-procedure pancreatitis. And then they were randomized essentially into 3 groups, irrespective of the results of manometry: biliary sphincterotomy, dual sphincterotomy, or no sphincterotomy, a sham group. And all the people involved in their care and evaluation, including the patients afterwards, were blinded to the treatment outcome, and they were followed for a year before the initial results were evaluated. In fact, we got funding to go out for a total of 3 years, and now actually out to 5 years, so there will be some more results to come. One of the most striking things before we got the results of the study was that in fact we found these patients were remarkably sane. There's a tendency to assume that they're all a bit crazy, but that's not the case. And we looked very carefully, we evaluated these people, all their psychosocial issues, anxiety, depression, coping, etc. And we found that their scores were really very similar to those of the general population, and less so than those reported for irritable bowel. So that was a surprise, and perhaps a good one. The results of the study, which were published in the Journal of the American Medical Association a few months ago, were fairly striking. For those who haven't seen them, we found that 37% of the patients in the sham arm who had no sphincterotomy were very satisfied indeed with a reduction in their pain at 1 year. And that figure, 37%, is actually remarkably similar to a lot of other sham studies that have been done, both in endoscopy and surgery. And it was remarkable to me that this placebo response lasted for a whole year, because we kind of thought naively that if the placebo would wear off after a few months. But when I got into the placebo literature in more detail, I found that's not the case. There are plenty of sham surgery studies that show the patients at a year or two are still feeling very happy despite having not had any active treatment. Now, the results in the sphincterotomy arms were surprising, to say the least. They were not only no better than sham treatment, but actually slightly worse statistically. And this was a bit of a shocker, because I'd kind of expected that we would find some patients who benefited and that we would be able to identify their characteristics, and that would be a useful step forward to refining how to treat some of these patients. But our conclusion was that, in fact, ERCP, manometry, sphincterotomy in this group of patients is not worthwhile. And I just looked the other day further, more data. These are patients who had no pain at all between 6 and 12 months, and you could see a quarter of them in each of those arms were completely pain-free, despite having had very bothersome pain to start with. To get into the study, you had to be almost disabled by pain. So, as I said, we were looking for predictors of success, but since we didn't really have too much in success, that wasn't very productive. But we didn't find any clinical features which made it more or less likely that the patient would have a good outcome, whether or not they had irritable bowel, etc., whether they were very anxious or whatever, the reason for cholecystectomy, whatever. None of those things seemed to influence the outcome. And even more, the results of sphincter manometry didn't predict the outcome either, which didn't entirely surprise me, because the idea that manometry is a gold standard has always been a bit worrying. It's something that's done for a few minutes in a sedated patient, may not be terribly representative of what's going on. And one other fact, which we've just been working out with one of our fellows, is that the manometry data were not that reproducible. In patients who had sham treatment to start with and came back for a second procedure, we found that the manometry result was only reproducible in just on half of them. So again, emphasizing the fact that sphincter manometry is certainly not a gold standard. We actually had another little study going at the same time of same people who did not want to be randomized. So there were 72 patients who underwent the same evaluations and follow-up, but it was open label. They knew what had been done to them, and you could see that the success rate was also pretty pathetic in that group. And we did that to make sure that the patients who were randomized were fairly representative, and they were in fact very similar. And not surprisingly, there were some substantial adverse events, despite the fact that these are all done by experts in 6 centers around the United States that you would recognize. Two perforations, one of which required surgery. Fortunately, no deaths. So our conclusion is that SOD3 does not exist, because there is no evidence for sphincter dysfunction in these patients based on this study. But that's not to say these patients don't exist. They certainly exist. There are a lot of patients with bad post-cholecystectomy pain that we need to actually figure out something better for. The sphincter is not the problem, and ERCP intervention is not appropriate. What else to do? Well, it's a question for all of you and for the young people who will be working on this in the future, because it's very difficult to know how to handle these patients better. But the one message that we want to get across is that sphincter intervention doesn't seem to be helpful and certainly dangerous. Now let's bring on to SOD type 2, where, as we said, these are patients, post-cholecystectomy pain, with some abnormality on the biliary side, a dilated duct or abnormal labs. And if you look at the cohort studies, you'll see that success is claimed in about 2/3 of those patients. The biggest study, I'll let you read this, it's amazing to me that the claim of success was based on the fact that patients didn't come back. And there are a lot of reasons why patients don't come back, and it seemed to be extraordinary. This is the biggest study that's been published in this area, and got a lot of publicity, but to me, I think it's rather embarrassing. Anyway, the belief in manometry and sphincterotomy in SOD2 is based on 3 small and old randomized controlled trials. And I put the 3 of them together, which is probably statistically inappropriate, but it's easier to read them. So these studies said if you had an abnormal biliary manometry and got a biliary sphincterotomy, you had a good chance of success, although success is defined in various different ways, not always blinded or objectively. But if you had a positive manometry and no sphincterotomy, half the patients got better. So this is really beginning to make me wonder whether SOD2 exists or whether some of these patients are not being treated appropriately. And the other point about these studies is that they're all focused on the biliary sphincter, and we know that pretty much half the patients you investigate nowadays, if you look at the pancreatic sphincter, about half of them have got pancreatic sphincter hypertension as well. So it's kind of amazing to me that just doing a biliary sphincterotomy seemed to be so effective. So we know that these type 2s are a mixed bag. I said already several times, it's defined by raised labs or dilated duct. I've already mentioned that there's really no consensus on what a normal duct is, and it might be much more interesting to look at a dilating duct. So if you knew what the size of the duct was at the time of cholecystectomy, and it's now twice the size, that suggests to me that there's something relevant about it. It's often said that if the liver tests are spiking with pain, go up and down with an attack of pain, that's very suggestive of a sphincter problem, but in fact that's never been validated, and it may be that actually those patients are just passing little stones that have not been detected. And we need to clarify these points, and that's what we're basically planning to do right now. I just got IRB approval to do an observational study looking at the management of patients with SOD2 with an independent blinded follow-up, and that I think is very, very important, because virtually all of the other studies have been done without blinding and without objective independent follow-up. It seems to us that there might be, in this observational study, 3 possible outcomes. One, it looks as if it works. In other words, we've got about 65% plus success. And if that's the case, then we've got a cohort in which we can look at the predictors, the things that actually make it more or less likely for them to be successful. Or the success may be closer to the placebo response, in which case we would have to ask whether this practice is legitimate. Or we'll have something in between, in which case I think we could justify a full-scale randomized controlled trial, which will take a while and a lot of funding to do. And then I want to pass on to functional gallbladder disorder, which is the concept that your gallbladder can hurt even though there is no pathology on regular imaging. I put EUS in brackets there because, as you all know, with endoscopic ultrasound, one can detect things that are not detectable by standard imaging, and a number of patients who've actually done well after having their gallbladder out for gallbladder dyskinesia probably had tiny stones. And then traditionally there's the ejection fraction on a dynamic isotope scan, which traditionally says that if your ejection fraction is less than 38%, you should have your gallbladder removed. And it's a fact that up to 20% of the gallbladders coming out in the United States are done for this so-called condition, but it seems to be confined to the United States. There's very little literature from elsewhere, and my inquiries of other countries and friends suggest that it's a rare event, if ever. And it's also true that the number of these procedures and the proportion of them are increasing in the United States. So the key question here is surgery really helpful? And is the high-dose scanning predictive of the outcome? And it's relevant that over half of the patients in our episode study had actually lost their gallbladders for this dyskinesia issue. And a third of the scans that were done in those patients were actually normal too. So that a lot of these gallbladders are coming out with no evidence of pathology and normal imaging. A wonderful review just come out in Digestive Disease and Science by Klaus Bielefeld and colleagues, questioning this whole area with a huge review of all published literature, ending up saying that there really needs to be a scientific, stringent, prospective study looking at this area, which is in fact what we're planning to do. Now, if you look casually at the literature, it suggests that up to 90% of patients with this condition actually improve, or they don't say cured, but improved, and improved is a pretty soft endpoint. But also, almost all of those, as you see, are retrospective. The results are assessed by the people who actually do the treatment. They're not blinded, and most of them have got incomplete follow-up. So there's a lot of questions as to the validity of those data. There's just one randomized controlled trial more than 20 years ago with only 20 patients in it, which suggested that indeed this was beneficial. Success in longer follow-up falls off. There's several studies showing much claiming much less success as you go along, and a Cochrane review concluded that we certainly needed further trials. So surgery is also used in patients with normal ejection fractions, and there is a couple of studies suggesting that if your ejection fraction is actually over 90%, that you're more likely to get a good outcome. And then there are some people who believe that if the patient's pain is reproduced by a CCK injection at the time of HIDA, that that's a good sign that the surgery is going to be successful. But again, that's not been validated. And the most striking thing is that, in fact, if you don't treat these patients surgically, an awful lot of them get better spontaneously. So there is certainly no rush to remove the gallbladder in this sort of context. Hepatobiliary scanning, you'll be aware of, is, as I said, being used very commonly in this context, and is very widely used. We did a study here some years ago because I was rather skeptical about this scan, which showed that in fact half of the asymptomatic patients that we evaluated had a quotes abnormal scan. So it suggested to me that it wasn't particularly useful. And there have been several major reviews, including the one I just mentioned, which question its value and recommending much further evaluation. So we've actually just submitted to the NIDDK a letter of intent for funding for a randomized controlled trial, randomizing patients to laparoscopic cholecystectomy or to laparoscopy, with the caveat that if something's found at laparoscopy, that can be treated at the time, and that we will be doing scanning by the standard method, and we'll be including people with whatever their ejection fraction if they have sufficient pain with a 1-year blinded follow-up. And if this gets funded, then I will be working on this for a number of years. I have 10 fairly well-known centers in the United States signed up to participate in this if we can get it funded. And like the episode study, we'll also do an observational study alongside to make sure it's generalizable. Main questions for this study is, could we actually do it? Is it possible to do a randomized sham surgery study? And the literature suggests that it is, and the centers that I've got involved seem to think that they'll be able to do it. Whether we should have some sort of medication trial lead-in to see who responds to medication. There's some very interesting new dynamic CT and MR studies which we might incorporate if we can, just to evaluate them at the same time. One of the biggest questions, of course, in any randomized trial is how many patients you need. And the problem there is you have to define what you mean by success. Obviously, theoretically, if the gallbladder is the problem, you remove it, that should get rid of the problem, right? But we all know that's not quite the way it is. And so we've been asking people questions, and I'm asking you this question because I've got a little handout that I'm going to spread around for you to actually fill in if you wouldn't mind. So just imagine that you have been having impressive biliary pains, maybe some of you have, and that you've had a scan which suggests that the ejection fraction is inadequate and you don't have stones. The question is, what's the least reduction in pain that you would accept as success? Obviously, everyone would hope to be 100%, but what would be the least? So where should we put the success threshold for surgery? Once you've worried about that, there's a second issue here, and that is, what's the least chance of achieving that success that you would consider acceptable? Those are two separate questions, but they're obviously interlocking, and they're very important to us in trying to figure out exactly how many patients we need to get into this study. So, as I said, there'll be some pieces of paper handed around that you can fill in and leave at the desk if you want to help us with that little bit of study. I'll finish by just mentioning the Rome Foundation, the International Foundation for Functional GI Disorders, which is called the Rome Foundation. A lot of you, I hope, are familiar with that. That's their website. The president is Doug Grossman, who's associated with the University of North Carolina. And because of this work that I've been doing, I've managed to get myself involved in that foundation that's having its fourth main meeting in Rome next month, where we're going to be discussing a lot of these issues. If anyone has any wisdom for me, I'd be happy to take it to Rome for you.